Good morning, pharmacology students. This is Dr. Sue, and this is the presentation for Competency 1 Basic Pharmacology, which includes the major concepts of pharmacokinetics and pharmacodynamics. Let's get started. The first slide just goes through some basics of pharmacology from the very early times. The first recorded information about any kind of drug compounds was in 2700 BC with use of laxatives and emetics. As we move through the ages, in 1240 AD, we saw the development of the apothecary system, and some of these measurements we still use to today, including grains, which are how we measure the aspirin compound. We then began to see the metric system coming into use, and this is the international measure that's still used today. And you know that because of the drug calculations done using the metric system, milligrams, micrograms, etc. In the 18th century, we began to see the first vaccines. We saw some of the original compounds that came from vegetative sources, such as the foxglove used to develop digitalis. In the 19th century, we saw the introduction of compounds that were derived from opium. Opium goes all the way back to the 1500s BC, and it was used by Egyptians to treat ailments. Morphine and codeine then were introduced at that time. In the early 20th century, we saw the compound of aspirin being developed, along with the first uses of insulins, phenobarbital, and sulfa. And then in the 1940s, we had the invention of penicillin, which made a big impact on the survival of the human species as it relates to treatment of infection. In the 1950s, then, we began to see even more increases in development of drugs, and it's carried through to what we see in today's modern times. And again, this is just a review. You are not going to be significantly tested on history in this course. So let's get started on the two phases then that we discuss related to basic pharmacology, and that is pharmacokinetics, or the drug movement to achieve an action, and then pharmacodynamics, which is study of the drug concentrations in the body and the effects on the body. So in pharmacokinetics, you'll see four major phases, including absorption, distribution, metabolism, and excretion. And these four phases we're going to discuss individually, so I'm not going to read the definitions to you, but I do want you to be working in Chapter 2 in your textbook and Chapter 1 in the ATI. It gives you a really good summary of each of these phases of pharmacokinetics. If we think about the word kinetics, we think about movement. So that is the movement of drugs through the body. This is a pictorial view for you, and it shows the four stages or phases of pharmacokinetics. This is a great visual for you. So the drug absorption is based on the route that the drug is given, but the destination always must be the bloodstream. From the bloodstream, we know distribution makes the drugs available to the body. And one of the concepts we talk about with distribution is protein binding. If the drug is bound to protein, the drug cannot be used at that time. The free drug is the drug that's available to be used to provide the action of the drug. So the drug itself can become stored in the body, it can be utilized, it can be metabolized primarily in the liver, and then excreted primarily in the kidneys. And we're going to talk about all of those phases in this next several slides. First, let's start with absorption. We know we have two types of compounds, water soluble and fat soluble, and that makes a difference as to how the absorption of the medication occurs. So fat or lipid soluble drugs pass quickly through the GI tract, and we know that 80% of medications are taken orally, so they absorb through the GI system. water-soluble drugs in this system require a carrier. And when that happens, the movement across cell membranes can occur in three primary ways. Passive absorption, which is diffusion and movement from high to low concentrations with no added energy required. Active absorption, which requires, of course, energy. It also requires a carrier, either an enzyme or protein, in order for the absorption to occur. And then we have pinocytosis, where certain drug particles can be engulfed and carried across a membrane. And this is just a pictorial for you of that absorption process, both the passive and the active forms. Pharmaceutics then is an absorption variable that we need to consider in any oral medications, right? So tablets, caplets, capsules. 80% of our drugs, remember, are PO or oral and administration. And they require some pharmaceutics in stages, including disintegration or breaking into pieces, and then dissolution, where those particles mix into a liquid base. We have something we measure called rate limiting, which is the time it takes for the pharmaceutics to make the drug ready for absorption in the body. So, for example, if we think about a drug that's in the form of a liquid, obviously it doesn't have to disintegrate or dissolute. It just becomes part of the absorption process, so it goes more quickly. And we're going to talk about these variables. So, what kinds of things impact pharmaceutic processes and interfere? So, the first thing is the excipients. And what do we mean by excipients? Well, the excipients, of course, are the fillers that the compound is mixed in to make the tablet. Some of them can interfere with the breakdown more so than others. In other words, some tablets dissolve very quickly if you drop them in water, and some of them stay solid for a much longer period of time. That's partly due to the excipients that the compound is in. And then we have to question, do we have a solution or a tablet? Okay, so a liquid cough preparation or a liquid form of a medication will be absorbed much more quickly, obviously, than a tablet. Another consideration is, do we have some type of an enteric coating, or do we have maybe a capsule that has a certain breakdown timing so that it slows the absorption of a medication? Certain foods will interfere or enhance absorption. So foods, for example, that are alkaline will slow absorption, whereas acidic foods will enhance the breakdown, the pharmaceutics for absorption into the system. So again, absorption and disintegration are quicker in an acidic environment and slower, of course, in an alkaline. So how do these things each affect the rate limiting of a compound? That's just a question that you should be able to answer as you talk through or read this information. Let's look then at drug absorption itself. So most oral drugs are absorbed in the small intestine, and oftentimes when there's diseases of the intestine, this can inhibit the absorption. Okay, so the villi, or those tiny microvilli, are what we depend on for the absorption of our drugs. Okay, if we have any damage or surgical removal of certain parts of our small intestine particularly, we're going to have a limitation as to the absorption. Also, we know that certain drugs cannot be given and absorbed through the GI tract because they will be destroyed, and one of them is insulin. That's why we inject insulin into our patients rather than giving that in some type of an oral form. Other variables that can affect absorption of medications, of course, we depend on blood flow. Okay, blood flow to the GI tract, blood flow in general to pick up the medications and allow them to be absorbed for distribution. We know that pain and stress can lower absorption and slow absorption rates. Food can slow absorption rates. If the patient is fasting and their stomach is empty, that's going to possibly increase absorption rate. And then we already talked about the pH. So we look, for example, at the different types of medications and IM versus sub-Q. IM, of course, because there's a higher vascular presence in the muscles, is going to absorb quicker than sub-Q because there's less blood vessels in the sub-Q tissue. Okay, so also the other membranes of the body, the mucous membranes, absorb very quickly because they're highly vascular. So the intranasal, your eye drops, your vaginal, rectal, and buccal areas will absorb medications fairly quickly. I encourage you on your own to go through and look at some of the absorption and distribution that occurs here and test yourself on that. And there's some sample questions even in the ATI materials that you can look at. The next important concept that we want you to understand is something that is called the first pass effect, and it's mentioned in your book on page 17. This first pass effect is an effect that the medications can go through when we absorb oral drugs in the GI tract. They pass from the intestinal lumen to the liver through the portal vein. In the liver, some of the drugs are metabolized to an inactive form and are excreted. So this reduces the amount of active drug that's available to exert the pharmacologic effect. This is called the first pass or first pass metabolism. Most oral medications have some degree of first pass metabolism. In other words, a certain percentage of the dose that you give is going to be eliminated directly through the liver, and the patient will not have that therapeutic effect from that portion of the drug that they take. So we have to understand that there are certain compounds that we don't give orally because of this first pass effect. A couple of them that your book mentions here are nitroglycerins and lidocaine, for example. They have a fairly high first pass metabolism, and most of the drug is lost if we would give it orally. Bioavailability then is the percentage of the drug that we give that actually is available to be active in the body. So orally administered medications can be affected, of course, by the absorption and the first pass metabolism, which can compromise the bioavailability. One of the key things to remember with bioavailability is that the only way to guarantee 100% bioavailability is by giving a medication IV. When you give it IV, you know the patient's getting 100%. Now, how does that affect how we dose patients? Well, of course, IV doses of medications are much lower, typically, than the same drug given in an oral form. Okay? And bioavailability factors also play a role here, so we have to consider including things like the drug form itself, the route that we're giving it, what's the integrity of the GI mucosa and the mobility, our peristaltic activity, if there's a presence or absence of food, other drugs that are taken with it, and then also if something is compromising the metabolism in the liver. The next slide here is just a pictorial for you of the different routes of administration of meds. And what I want you to do is pull out your ATI Chapter 1, starting on page 5 through page 7. It talks about all of the different routes and specifically different nursing actions that you need to take for each route of administration. And I want you to review that very closely. It talks about the advantages and disadvantages of each route And I want you to really do a good review on that. It's a great resource for you. So some of the advantages and disadvantages, obviously, of the routes we know with the PO. Obviously, it can limit the absorption depending on many factors we depend on. The integrity of the GI tract, the amount of absorption if it's a high first pass compound, and the list goes on and on. The advantages of it, though, is that the ease of administration and the patient's ability. It's inexpensive, it tends to be convenient, and it is the safest route for administering meds. And then you can go through all of these routes yourselves and use that Chapter 1 in ATI as your resource for the advantages of and disadvantages of each. The next thing we're going to talk about is the distribution of medication, and this is the transport of those drug molecules in the body. So we of course know that it's dependent, the patient has to have an adequate circulation, otherwise we know that distribution of drug will be compromised or lower. A patient with severe vascular disease or a patient with diabetes that has, let's say, a lower leg infection, the disease process itself will change the vascular system, which will compromise the circulation. So that's a big factor. Also, we need to understand the drug's affinity to tissues. And the greater the affinity, obviously, the better effect we're going to see. Therapeutic effect. Protein binding effects, then, again, remember that has a factor on how much free drug is available to cause the action that we're looking for. And then we have something called a measure of volume of drug distribution. That relates to both the drug doses and the concentration in the body. We also measure distribution in relation to the half-life of a drug, and we're going to talk about that in subsequent slides. Okay, this chart is also in your book, and this just demonstrates for you what it looks like with the protein binding, the free drug molecules along with the protein molecules, and how that affects the available drug to us. So the only available drug are these little blue dots. All the blue dots that are attached to a protein are unavailable for action in the body until they release themselves from the protein and allow themselves to be absorbed and distributed in the body tissues. The more highly protein bound, the longer the duration of the drug. So it's a slower process the more highly protein bound it is, and we have to consider that when we're thinking about which medications we're giving and how long it's going to take for us to see a therapeutic effect. And this just is a description of the highest to lowest protein bound concentrations. So we know that the only drug that produces the action in the body is the free drug. So obviously, if we have high protein binding, the more high protein binding we have, we have less free drug. Okay, so if we have a patient that takes 2 or more highly protein bound drugs, it'll increase free drug of one of those because there's only a limited amount of proteins it can attach to. And in those patients, we're concerned with drug toxicity. We also have to think about patients who have low protein levels, that they're going to have a limitation of proteins for that drug to attach to. That will also increase free drug and also have a risk for toxicity. Patients at risk, of course, are those who have liver and kidney disease, malnourishment because they have lower albumin and lower protein levels. And there are other reasons why people have low albumin levels besides malnourishment, but we also see it in the elderly. They tend to have pure protein binding sites and they have an increased rate of poor nutrition. A couple of the protective barriers in the body that we want you to be aware of, and we just need for you to understand it at a basic level, are the blood-brain barrier and the placental barrier. And this information is also discussed on page 18 in your textbook, and there are the same diagrams that I'm going to show you in the next couple slides. But the protective system of cellular activity at the central nervous system is there because we need to protect the brain and the spinal cord from invaders or foreign invaders or poisons. But this also means that we need the drugs that pass over that blood-brain barrier tend to be your highly lipid soluble drugs. The non-lipid soluble drugs do not pass across that barrier. The placental barrier is a protection for the fetus, so that when mothers ingest certain drugs, there's a placental barrier so that it tries to limit the amount of drug that is absorbed across that membrane. We do have pregnancy categories, and we know that A and B tend to be the most safe meds. When we start getting into a level C, that has a higher risk, although there isn't actual documented evidence until we see a pregnancy category D. The pregnancy category X are compounds that have shown that they cause teratogenic effects in the fetus during study of animals, and we don't recommend those at all. So this is just a pictorial of the distribution across the blood-brain barrier, and that's in your book. And then the drug crossing over the placenta is the same. The next thing we're going to talk about then is metabolism or biotransformation. And the metabolism is the process by which we change the drug from lipid soluble to water soluble so that our body can excrete it through the kidneys. The metabolism of this drug compound to be excreted, it occurs in the liver. And so the liver is thought of almost like a sewage treatment plant where everything has to be treated before it can be eliminated. So this is the most common place where drugs are inactivated in the body. Okay, so most drugs come into that area in order to be broken down and from a lipid to a water soluble compound so that they can be eliminated. And the most common problem we see with metabolism of drugs is when there's liver disease of any sort. So people who have liver disease tend to have very high chances of drug toxicity in their body. So we have to be very careful about that. And we want to always be looking at what a patient's liver function is by reviewing liver enzymes, as you can see here. The ALT and the AST are the most common ways for us to monitor that. We want to talk about the drug half-life, because drug half-life is the way that we have a measure of how long it takes for the compound to reach a therapeutic level. It all plays a part in that. So a half-life is the time it takes for the serum drug concentration to be decreased to 50%. And the reason that's important is because it's the way that we set up dosing of a med. So this has an effect of metabolism and excretion of a drug, and we want to make sure that 90% of drugs are eliminated with several half-lives. So short half-lives tend to be 4 to 8 hours, longer half-lives are greater than 24. And we want to try to maintain a steady state of concentration. So in order to do that, we typically have to dose a person so that they can have 3 to 5 half-lives reached by the time we get to the steady state. Well, what does that mean? Well, let's say we have a drug that has an 8-hour half-life. Let's say it's an antibiotic. Let's say it has 100 milligrams as its dose, so it's a new drug. So at 8 a.m. we give that 100 milligrams. We then are going to be giving another dose at 4 p.m. So we're going to give another 100 milligrams, but only 50% of the first dose is gone. So now we have 50 milligrams left. So that's 150 milligrams. Okay, then when we get to midnight, 8 hours later, we still have 75 of that 150 left, plus we're going to give 100. So now we're at 175. And it just keeps going from there. And typically we can reach a therapeutic concentration within 3 to 5 of those half-lives, which is usually within 24 to 48 hours of administration start time. So elimination then is the removal of drugs from the body, and elimination can occur in all the areas that you see here listed, but the most common one, of course, is the kidneys. They filter the free unbound water-soluble drugs and drugs that are unchanged. Protein-bound drugs are not filtered by the kidney until they can be released as free drug. And then they still may have to go to the liver to be broken down from a fat to a water-soluble compound. Now the lungs are usually only reserved for elimination of volatile drugs, things that are metabolized by CO2 and O2, CO2 and water. That's usually what happens, is that the metabolites become carbon dioxide and water and are exhaled out of the lungs. And the most common compounds that you see excreted that way are your centrally acting anesthetics and analgesics. So inhaled anesthetic, patients who are post-operative, we encourage deep breathing coughing because their body is ridding itself of all those potent volatile chemicals that rendered them unconscious during surgery. What do we have to look at related to elimination of drugs? Renal or kidney function, right? So any patients that have any compromised in their kidney function will retain more drug compound. You have to think of that. That's the common take-home message. So every phase of this pharmacokinetics depends on certain organs. Specifically, metabolism focuses on liver and excretion, of course. Elimination depends on our kidney for the vast majority of drug compounds. So we really want you to understand these concepts. It's the renal or the kidney clearance of drugs can be affected by the pH of the urine. The more acidic urine will rid itself of some compounds, whereas other compounds depend on alkaline. And so that's important for you to understand. We have to understand a couple of ways that we measure renal function. Most commonly the blood test of blood urea nitrogen, or BUN, and a creatinine measurement, the two of them combined, not just one and not just the other. And we tend to also sometimes measure accurate function of the actual filtration of the kidneys through the glomeruli by doing creatinine clearance tests. And we know that the creatinine clearance will decrease with age. It will decrease in women due to less muscle mass. But these are all important things to recognize related to kidney function. Pharmacodynamics then is the next thing we're going to talk about, and that has to do with the study of drug concentration and effects on the body. We have two different measures that we look at. We look at both the primary desirable effect and the secondary effect. So, for example, in a primary, let's just use the compound Benadryl. If a patient is having an allergic reaction, let's say they break out in hives or a rash, and we give them a shot or a pill of Benadryl as an antihistamine, and that's the class of medications it's in. But it has a side effect, a common side effect of drowsiness, okay? So in a primary pharmacodynamic, we use Benadryl to counteract an allergic response to something. In a secondary, you see Benadryl being used in combination with Tylenol or ibuprofen for patients to use at bedtime to promote sleep. And so what they're doing is the side effect of drowsiness, it becomes the secondary desirable reason why that person's taking that medication. It's not because they're having an allergic reaction. It's simply because they want to be drowsy so they can go off to sleep. Okay, now there are undesirable things about that too. So if we have to give a patient Benadryl because they've had an allergic reaction to something, if they have to get in a car and drive home, now we have an undesirable effect of drowsiness where they could have, be impaired and not be able to function properly to drive themselves home. So that's just one simple example of how this works. So another thing we look at then with pharmacodynamics, and again we're talking about this in chapter 2 of your book starts on page 19, is something called the dose response. And this is the body's physiologic response to changes in the drug concentrations at the site of action. So we have dose ranges, of course, that we look at that vary from patient to patient, okay? The maximal efficacy is the maximum drug effect or the greatest effect from the drug. It doesn't help to increase the dose. Increasing the dose beyond this maximal efficacy is basically a waste. It will not give you a greater effect. And this diagram is found on page 20 in your book, and it shows you that therapeutic effect along with the index where your sweet spot of your dosing is, and then when you're getting close to that toxic effect. Onset of action is another measure we look at then. We look at onset, peak, and duration of action as measures. These are aspects of pharmacodynamics that you need to understand. We want to know how long it takes before the drug action starts and reaches what we call a minimum effective concentration, or MEC. Then we see a peak action at a drug at its highest therapeutic concentration, and then we see the length of time that this pharmacologic effect is produced, which gives us our duration of action. We also use a measure called MTC, which is the minimum toxic concentration, and if we go over that MTC, then we can be at toxic levels of a drug. And this is referred to in something called a time response curve, the onset, peak, and duration of action curve. And you can see how this is measured. So in order to maintain the therapeutic ranges in a drug, we give a drug the first time, and maybe 6 to 8 hours later we're going to give another dose, because as the elimination of that first dose occurs, we now want another administration to start coming up into the therapeutic range so that we can keep drug in this sweet spot right here that I talked about. On occasion, we also do give something called loading doses of medication, and loading doses are given with certain compounds that need to have a higher dose to raise that drug to a therapeutic concentration quickly and then maintain it so it achieves a rapid MEC. One of them is digoxin, as an example. We also can measure certain drugs that we monitor very closely, and particularly those that have a low therapeutic range. So they have high levels of plasma concentration at their peak and low plasma concentration, and we measure peaks and troughs, and nurses are involved in that because we are the ones administering the drug, so we have to time the blood tests after we give a dose of a medication so that the information provided to the physician or other provider who's going to possibly adjust the doses can be accurate. So that's the key piece for the nurse. And this just shows peaks and troughs and how they're measured. Typically, there's a peak reading taken an hour after you complete a dose. So for example, a dose of IV antibiotic, vancomycin is a common one that we give, and that one, let's go back. So in vancomycin, after you complete your IV piggyback dose, you start the clock, and an hour later you draw the blood test to see what your peak level was, and then that's going to affect, and then you take another measure 30 minutes before the following dose is due to see how much has dropped off, and that's going to affect how they dose the patient going forward. Okay, another important piece to consider with pharmacodynamics is called the therapeutic index, and this describes a relationship between the therapeutic dose of a drug and the toxic dose of a drug. And so those meds that have a low therapeutic index tend to have a higher risk of toxicity. And that's really what is a take-home message here. And it's shown here on this next slide. So here's your drugs that have a low therapeutic range, a low margin of safety. Usually you're measuring blood levels. And what are some of the other needs that we need to think about? Well, we need to think about dosing and toxicity symptoms in your patients. So, for example, digitoxin, we know digitoxicity shows specific signs and symptoms that we see in our patients, and we measure dig levels in the bloodstream to see whether they're in a therapeutic range or if they're becoming toxic. Our safe medications, most of our meds we give have a high therapeutic range. Now, most of our oral medications are high therapeutic range. They tend to be our safer drugs. They have a more consistent and they have a larger range of therapeutic response with a very low level of toxic response, if any. And they still have side effects. These medications that are high therapeutic range can still have side effects, but they're safer to give than those that have the low therapeutic range. Another thing you need to understand related to pharmacodynamics is what we mean by agonists and antagonists. And these are kind of two different ways that we see the relationship with receptors in the body and the desired response of drug compounds that we give. So when we have drugs that activate a receptor and produce a desired response, that's called an agonist. When we have drugs that prevent the receptor activation or block the response, those are called antagonists. And you're going to see these terms used again going forward. I'm not going to get into too much detail with this. You just need to understand the concepts of what we mean by the agonist drugs versus antagonists. In fact, we're going to talk a lot about those in the next competency lecture with autonomic nervous system. Okay, this slide shows us quite a few definitions that we do want you to understand. Your book does a really good job of defining them. Side effects, of course, are secondary effects of drug therapy. All drugs have certain side effects. But in some instances, they may even be desirable, as we talked about before. Adverse drug reactions, of course, are unintentional and unexpected reactions to drug therapy that occur at normal dose ranges, and this may require us to make adjustments. You also have to understand some of the other terms such as the tolerance, the placebo effect, and all of these definitions are found right in your book on page 22 and 23. So I would encourage you then to look at all of that information very closely. A lot of the terminology is described here as well. So it's really a good resource for you. What other things do we have to consider related to interactions and absorption? Well, we have to think about interactions with two different drugs. So when we think about absorption, we look at how the rates of absorption for one or both drugs can change if we're given multiple drugs based on whether we have increased GI gastric emptying, if there's a change in pH, if certain drug complexes are formed that do not work in the body, anything that can impact one or the other of the compounds. The amount of protein binding, of course, can affect this. Also, we know that foods can affect absorption, and because foods obviously can change, right? They can change the pH, they can increase, decrease, or delay absorption. So distribution of the drugs, of course, can also be affected. As I said, the protein binding in the bloodstream, and we may need to decrease doses of highly protein-bound drugs if we're giving more than one, especially because there's competition at that protein level. So some of the other factors that will affect distribution are the drug concentration itself, the protein binding power, and also the volume of distribution, how much of the compound was actually able to be distributed. You have a lot of information about this also in your textbook. Page 24 and 25 talk about this. Sometimes the larger volume drugs have a longer half-life and they stay in the body longer, and that can impact the effects that you see, the therapeutic effects on the body. Other things that can affect metabolism, of course we're looking at metabolism of the drugs now, there are certain things in our body that are enzyme inducers and certain things that are enzyme inhibitors. And something that is an enzyme inducer will increase the metabolism of another drug and promote elimination, giving us less drug action, and the inhibitors will decrease metabolism. So there may be a rapid onset. You may see an increase in the half-life of the second drug based on what's happening. You do not need to understand this this is really a provider level understanding, but you just need to understand that we can see these kinds of effects in the body between certain compounds. So you just have to understand the interaction between medications that you're going to be administering. In elimination of drug and food interactions, there's a general rule. Any drug that decreases cardiac output will also decrease blood flow to the kidneys, which will decrease our excretion of drug. So if we're slowing cardiac output, which will slow blood flow to kidneys, we will lower the excretion of drug rate, and that can increase risk of toxicity. So always be thinking about that. You just have to connect the dots and see how the function of our kidneys and the function of our liver, along with our circulation, are a dynamic that go back and forth that can increase or decrease drug concentration in our body. Most drugs are excreted in the urine, as you know. Some are excreted in bile and in the GI tract. Another factor to think about another few factors to think about with pharmacodynamics are some of the interactions that we can see. So the first one is something called an additive drug effect. We also can have synergistic effects and antagonistic effects. So if you look in your book on 25 and 26, you'll see that when we are giving two drugs in combination, the response can be increased beyond what either could produce alone. This is called an additive effect. So for example, if we give a diuretic and a beta blocker to lower blood pressure, we're going to see a better response than what we would if we just gave one of them. There also can be synergistic effects of medications, and sometimes we combine medications so that we can actually lower the doses of each of those medications. So for example, if we give something that's a sedative hypnotic, okay, let's say that we have we're looking at if we have two central nervous system acting medications. So let's say we're giving a narcotic for pain, and now the patient is anxious and is going to need a sedative hypnotic. We may modify the dose of the actual narcotic when we add that sedative so that we can see a synergistic effect and the patient will get the same amount of comfort. So it just depends on the combination of the drugs to cause a desired effect. Antagonistic effects, of course, are those that one medication can block the effect of the other. And sometimes we see this, for example, with medications, for example, like a narcotic. And sometimes we're looking for that effect. So, like if we get a narcotic, if we have patients that are given a narcotic and they get too much medication in their body where they start having respiratory depression, we're going to give something called Narcan, which causes an antagonistic effect to reverse the effects of the original narcotic. And that's just one example of an antagonistic effect. So these last few slides talk about some of the resources we want you to draw upon. Of course, our pharmacist is our number one resource when we're in the primary care environment or the acute care environment. And what is really their role? They interact a lot with nurses. You will come to rely on your pharmacist for just having a more consistent approach to knowing the interactions of the drugs, the IV exposures, what gets along with what. They're always a good resource, and we also have all of our drug reference books that you see here, your textbook, a nurse's drug handbook, and in the acute care environment, most of your medication administration records in the electronic system have an automatic link to Micromedics, which is really nice. You can look up the meds right on the spot when you're giving them if you have any questions. Another aspect of medication administration that you always have to keep in mind is the over-the-counter preparations. There's an increase in the number of them. What are the disadvantages and advantages of that, and what's your nursing role? We know that the nurse has to take a good history and ask the questions, are you taking over-the-counter preparations? Because if you just say, can you tell me what medications you're on? Many patients only give you their prescription medications. They don't even think of their over-the-counter preps that they're using. They don't think about their herbs. They don't think about any supplements they're using. So all of the vitamin supplements, you need to ask specific questions and be very clear in order to get a thorough feedback of everything, every compound that they're putting into their body, because that can affect how they react to prescribed medications. We also have to consider whether the patient has some type of an addiction, if there's a tolerance we start noticing, or if we're seeing any withdrawal symptoms at all. And I think 3 to 5 days is even late. We actually can see alcohol withdrawal within 48 to 72 hours, including nausea, convulsions, and hallucinations. So we have to be in tune to that as it relates to drug and medication administration. Some of the other things about over-the-counter preps is the drug interactions that we see. Oftentimes are liquid form of antacids, for example. When they're taken along with prescription medications, they can basically negate those pills that the patient took. They will inactivate the drug. They can have an effect like milk of magnesia can wipe out the therapeutic effects of a blood pressure lowering agent, and the patient can not have the drug response they need to keep their blood pressure down. So these are all things we have to consider. We also have to look for overuse or overdosing. Patients will do this. We have to think about drug interactions. They don't always follow the directions of the over-the-counter preps. And that's about all I have for you today. The last several slides here are just questions for you as practice for you to take yourself. The answers show on the transcript form of the notes. So I hope you have a good rest of your day, and thank you very much.